The broadcast is now starting. All attendees are in listen-only mode.
All right, good morning, everyone. I think I'm going to go ahead and get started. It looks like it's just after 11:30. Welcome. My name is Renee Bradley. I'm the Chief of Research and Evaluation at the Mental Health Services Oversight and Accountability Commission. Thanks very much for joining us today. I was asked by CIMH, who is doing the business plan for DHCS, to provide a webinar for the evaluation work group that basically just gives a bit of an overview of the evaluation projects that the OAC has done and also has currently underway. I'll also talk a little bit about the evaluation efforts that we've got planned for the future. But my intention here is to really just give a very broad overview of what's been done. In many cases, if we've done these projects already or if they're already underway, we oftentimes have reports on our website. So you'll see on this first screen, I've got the OAC's website on the top, and I've also stuck that at the very end of the slideshow as well. But if you want further details about any of these specific projects, I'd encourage you to check out our website and or email me, of course, and I'm happy to sort of point you in the right direction so that you can read the reports and find all the details out for yourselves. But otherwise, I'm going to go ahead and get started by giving just a little bit of some background regarding why the OAC does evaluation. So for the most part, when you look at the welfare and institution codes, we see that there's a statutory rule for the OAC to evaluate California's community-based mental health system. And our evaluation efforts are generally geared towards quality improvement in the systems as well as services throughout the state of California. And in addition, our evaluation efforts are geared toward being able to provide information regarding system performance to everybody throughout the state, basically, so the governor, the legislature, clients and family members, as well as the general public. So in the past, our OAC Evaluation Committee has actually adopted a policy paper that sort of describes some of the core research questions that they feel as though the OAC should be focusing on, and I've got those listed here. So for the most part, they want to be able to explore how the funds have been used. So how have monies coming out of the MHSA specifically been used? So who has received services, what services were provided, and whether or not the spending that's been done was in line with the requirements as well as the plans that the counties provide to us. In addition, they want to be able to look at the impact of investments on mental health. So this is probably what most people think more traditionally of when they think about evaluation. So here we talk about individual outcomes for those who are receiving services in their families, whether or not we see improvements or not, whether or not we see changes to the community-based mental health system, and whether or not we see changes to the broader population, specifically with mental health outcomes. And then third, we do want to be able to look at what could be done to improve the efficacy of our investments. So we would like our evaluation efforts to try to be able to promote best or promising practices, as well as be able to identify ongoing gaps and challenges and limitations that might get in the way of being able to achieve our goals. So when you look at these three questions, we have definitely started to address some of them, although we've got a ways to go before we can really say that we've done this at a very thorough level. And today I want to, again, really just briefly walk you through some of the things that we've done at the OAC with regards to evaluation. So this slide just gives you an outline. It's a lot of text, I'm sorry about that, but it just gives you a brief summary of all of the completed evaluation projects we've done, those that we have currently underway or that are ongoing, and then at the end it lists some of the upcoming evaluation projects that we have in store for the near future. And I have provided in parentheses the contractor who worked on each of these specific projects or is working on this specific project. And I'm going to go through and highlight some of the, in the cases where it's completed evaluation projects or things where we do have outcomes or findings, I'll highlight some of those, but just generally give you an idea of the objectives of each of these. All right, we'll start with the completed evaluation projects. So this first project was, in essence, we asked folks from UCLA and their subcontractor EMT to look at activities and costs pertaining to the MHSA, and they did this for fiscal years 2006 and 7 all the way up through 2008 and 9. And what I've got listed here again are just some highlights. So from that report, we learned that throughout those fiscal years, total MHSA expenditures were $1.7 billion. The majority of those expenditures were related to the CSS component, community services and support. We found out that for that one fiscal year, 8 and 9, the MHSA accounted for about 1/4 of public community mental health budgets, so it gives you an idea of how much the Act is specifically contributing to the greater community health system. And then within that same report, they also went into detail about each of the individual MHSA components, beyond just CSS. So they looked at things like PEI and WET and innovation and whatnot. And again, some highlights are they did find that all counties are currently expending funds, or excuse me, at the time of the report during those fiscal years, were expending funds on community services and support. They found that at that time the requirement to expend the majority of those funds on our full-service partnerships was met across the state. And at that time, about 1/4 of counties were beginning to expend funds on prevention and early intervention projects. All right, so this is an activity or a report that we're sort of going to continue to work on. So our next steps here are we've had UCLA and EMT actually add the next fiscal year, 2009 and 10, to that summary of MHSA activities and costs. And that report is currently being reviewed by the OAC and will probably be released to the public early next year. In addition, UCLA and EMT have done 3 brief reports, we call them, focused on some specific things that we had an interest in. So one of the brief reports will focus on county-level variation in full-service partnership costs and cost offsets. A second report will focus on the capital facilities and technological needs. Those 2 will probably come out in early 2013. And then the third brief report was focused specifically on outreach and engagement, and that one will most likely be released a little bit later, probably toward the end of spring next year, if not early summer. So the next project that we've completed in the past, this is a bit of a summary and synthesis of previously done MHSA evaluations. So we had, in this case, UCLA and their subcontractors, CLS Research, do a little digging into what other entities, so for example, counties and other organizations have done as far as evaluations within the scope of the MHSA. And we had them focus on the community services and support component as well as prevention and early intervention, and the third thing was just general MHSA values. I think I've got some highlights from the CSS findings as well as the PEI, prevention and early intervention findings. So generally, again, at this time, and this is a date that was submitted, or excuse me, the report was submitted in late 2011. So this is a summary and synthesis of things that were done prior to that time. The CSS evaluations generally focused on the outcomes I have listed here, so homelessness or living situation, acute psychiatric hospitalization, arrest and incarceration, physical health emergencies, education, mental health functioning or quality of life, and employment. And for the most part, these CSS component evaluations actually did focus on the FSPs, our full service partnerships. And so when our contractors, in essence, went out and reviewed all of the information regarding the evaluations that had been done, they found some interesting things. And so here I've got on this next slide just example findings from that summary and synthesis. So for example, within homelessness, when clients did participate in CSS programs, and this is one that did focus specifically on FSPs, there was an association with reduction in homelessness, which is a good thing. Similarly, you see the days spent in restrictive housing, things like residential treatment, decreasing when individuals were participating in those programs. And on the flip side, you see the days spent in independent or residential living situations increasing. So these are all things that we would like to see happen. And then as a second example, when we looked at acute psychiatric hospitalizations, as far as, again, summarizing some of the work that has been done by other entities outside of the OAC, we did see that within some of the evaluations there was an association between community services and support program participation and reductions in acute psychiatric hospitalizations, and that's likely because episodes for mental health emergencies actually decreased when individuals were taking part in those programs. So again, all things that we like to see. These are outcomes in the direction that we'd want to see happen. So my next slide is just an example, again, from that same summary and synthesis of some of the findings that were identified when evaluations were done focused on prevention and early intervention. And I just want to give some caution here that within each of these sample outcomes or sample findings, these were all done with very small samples, so you have to interpret them with caution. But again, we see some good stuff. So PEI program participants generally showed decreased behavior problems and improved social competence and improved social skills. Again, good stuff. Programs specifically for our TAE, those transition age youth, seem to have a positive impact on outcomes like employment, homelessness, and involvement with the justice system or legal involvement. And then finally, when some of those prevention and early intervention programs had a parent focus, so they included the parents of those children, those seem to have positive outcomes as well and resulted in things like improved parenting knowledge and skills and self-efficacy, improved family functioning, and decreased parenting, depression, stress, and anxiety. So it seems like from some of the smaller evaluations that have been done, some of the prevention and early intervention projects that are out there are actually doing good and leading to positive outcomes with the intended population. So this next study is moving on to a new study that was done, a different study that was done by UC Davis, again contracted by the OAC. They focused this on assessing California's adult mental health needs, and I believe they based all of this information from the California Health Interview Survey. So they just tried to generally get a better understanding of the needs of adults who have mental health needs throughout the state. And they found that, again, just highlighting some of the main findings of California's 26.9 million adults, about 8.3% or 2.2 million do have a mental health need. And adults with a mental health need were more likely to be all these different characteristics, so more likely to be female, younger in age, have incomes below 200% of the federal poverty line, have no health insurance or public coverage, and also more likely to be American Indian or Alaskan Native. And then the final point I thought was interesting to highlight was 50% of those with a mental health need actually reported getting no treatment for their disorder from a primary care physician or a mental health professional. So it just highlights there is a need, but not all of those who have a need are actually getting the help and support that they could probably benefit from. So we also worked with UC Davis to use geographic information systems to understand mental health needs and utilization. So this is a sort of geo-mapping study that they did. And it's a pretty cool method, and I would urge you to look at the reports that are available on the OAC's website, because you can get sort of these interesting pictures of the states where you get sort of these, they do these hotspot analyses, and you can see sort of different color patterns that highlight just variation throughout the state in the outcomes that they're focused on. And so the first point here says that analysis of penetration rates using census tracts via this hotspot analysis basically they found statistically different levels of access to mental health services and different levels of utilization of mental health services. So that's something that probably merits further attention as we move forward, because you see that those differences based on regions throughout the state. All right, so I'm going to move on now to the currently underway and ongoing evaluation projects that we've got that we're doing here at the Mental Health Services Oversight and Accountability Commission. So the first one is what we call our FSP, or Full Service Partnership Data Quality and Corrections Plan. And this is a contract that we have currently underway with Sacramento State. It's been going on for at least the last year or so, and will continue on through 2014. And there were two primary objectives here. The first one was to assess the quality of full service partnership data, and FSPs, we received data about FSPs via the Data Collections and Reporting System, the DCR. And so we asked our contractors at Sacramento State to do a little digging into the DCR and make recommendations about, first and foremost, what are the limitations and the problems that they see, but also how can we actually try to overcome and get beyond some of those limitations. And so they did a lot of information gathering, not data collection, but information gathering by interviewing people throughout the state, people at the counties, at the provider and at the vendor level, as well as interviewing stakeholder groups. And they did a really nice summary regarding issues and recommended potential solutions to those issues, and put together this sort of best practices document regarding how to collect and report high-quality information about full-service partnerships via the DCR. On this next slide, I've got really just a few sample issues and potential solutions that were highlighted by the contractors at Sacramento State. I mean, they've got like a 100-page document about all the different issues and ways to address those issues. So again, I'd encourage you to look at the OAC's website to see the last version of that document that was submitted. But just to give you an idea, one of the problems that they identified was, you know, there is limited training available for the staff who actually have to use the DCR data collection system. So of course they recommended that all staff to receive both FSP and DCR training so that they have a better understanding of what the full service partnerships are all about and how to actually accurately collect and report information regarding those FSPs to the state. The second problem I have listed here is the data collection forms that are actually provided to them by the state appear to be difficult to use. Not all of the users understand how to use them. And their solution here was to create an instruction manual that would accompany all of those forms. And then the third problem that they, again, sample or example problem that they identified was there appears to be no defined process for collecting key event information. And so they proposed to create and define a standardized process for collecting this information. So the second objective with this was not only to identify those issues, but actually to implement solutions with them. So in some cases, where possible, once they identified something that could have been done to address the issue, we have had them go about starting to do that. So for example, they have created a DCR user manual that the end users can use. They've created a series of in-person and online user training curricula. So they've actually they did a webinar that you can download from, I think it's at the DHCS website. They go out and have done in-person trainings with the counties. They have a series of regional trainings actually going on in the future. I think they're scheduled to meet with Sacramento County, if not next week, the week after, where they will really work with them one-on-one to sort of see what are their current issues and where could they use further support and help in learning how to appropriately use the DCR data collection system. And they also updated the DCR data dictionary, which is just this document that basically describes all of the different variables that might be included or that are included in the DCR and provides definitions of them. And so this specific contract, like I said, is still underway, and we are going to work with Sacramento State to continue to identify problems with the DCR and implement solutions through 2014. So sort of related to this, we do here over at the OAC do ongoing assessment of the data collection and reporting systems. We realize that in order to do high-quality evaluation, we need to have access to high-quality data. And so this is just a summary of some of the issues that our contractors have identified that might contribute to low-quality data, inaccurate data, or just a simple lack of data. So within the scope of all of our contracts, we always ask the contractors to, in essence, assess the data that they have access to and let us know what are the issues that they are faced with so that we can keep track of those and hopefully be able to eventually identify resolutions in the long run so that we don't continue to address or face those same challenges. And when you look at all of the different issues that have been identified, they sort of fall into these different categories. For the most part, there are oftentimes problems with the actual reporting systems. So if they are collecting data, how do they get it into a system so that the information can be accurately reported back to the state? Oftentimes we've seen a lack of knowledge regarding use of the reporting system, so a similar issue there, just people not knowing how to use the system properly, or there being ambiguity regarding how to do it properly. Third, we've seen problems with the data collection and data entry infrastructure. So just the system may not be working properly, and there's really nothing that the providers in the counties can do about it. They're sort of at the will of the state to address those issues, and so if they're not able to enter it, maybe they won't do it, or they don't have a chance to actually revise issues that they see. So there's a problem there with the infrastructure. There's also a lack of knowledge regarding data collection and data entry. So the methods that they use when they have individuals, the clients, there with them to actually gather information from them sometimes can lead to issues with the data. And then once they do collect that information from the clients, how they enter it into the system, again, they just don't always know how to do that or have the support to do it accurately. And then finally, there appears to be a lack of knowledge regarding what specific data to collect, as far as especially what would be helpful to the state. This is not always apparent to them, and they're sometimes left to their own devices to figure out what they think would be appropriate and important to collect. And so overall, the OAC feels that these issues definitely need to be addressed in order to improve the quality and availability of data needed to evaluate the community-based mental health system. All right, so moving on to our next project. This is a project that is just about come to its end, our full service partnership cost and cost offset report. It was just released to the public this last November. And here the primary objective was to summarize expenditures of MHSA funds for full service partnerships. And this was also a study done by UCLA. EMT sort of took the lead on this. And what they did was identify a per-person annual cost average and range for program services and housing costs. And then they looked at offsets or savings based on savings incurred for incarceration in both mental health services and physical health services. And they did this for years 2008 and 9 and 10. And they broke everything down by age group when they could, so children, youth, and families, transition age youth, adults and older adults. And they have provided us with a statewide cost average as well as individual county costs and cost offsets. And again, I'm just going to highlight some of the results that they found. So as far as the costs, the statewide annualized expenditures per client, so for fiscal year 2008 and 9 was $23,600, and in fiscal year 2009 and 10, it was $19,700. So you see a slight reduction here across those 2 years. They also identified that MHSA funds are oftentimes used to leverage federal Medi-Cal funds. And then finally, they found that about 21,000 new clients enrolled in the full service partnership in both of those years. And there was an increase in enrollment between the 2 years. I see a typo there actually, so that line should be fiscal year 08 and 9 and 9 and 10, just for your reference. And then as far as some highlights as far as what they found regarding the cost offset, so savings incurred by actually providing individuals with a full service partnership program, they found a whopping 75% savings for fiscal year 8 and 9 and 88% savings for fiscal year 9 and 10. And so when you really look at this, it looks like for every $1 of MHSA funds that were invested in these programs, there was a cost savings in other services of about $1.27. And when you look at both years, when the total cost is compared to the total offset, the percent savings equals about $161.5 million. So clearly we can see that it seems like putting individuals through this program is doing good, not only for them, but we're actually getting back on our, getting a bit of a return on our investment. So that's helpful to know. Okay, so going on to the next project. This is a study we've also done with UCLA, and this is something that's currently underway, and we plan to continue on through 2014, and we'll actually sort of go through and stem into a larger performance monitoring that we hope to do on an ongoing basis. We looked at trends in what we call our priority indicators. And so here we have a series of priority indicators that were initially approved by the Planning Council and the Commission. And when I say indicators, in essence, I'm talking about how we determine whether or not outcomes that were outlined in the Mental Health Services Act are being achieved. And so with this project, we wanted to be able to establish trends in both system-level outcomes or indicators as well as individual level priority indicators for both full-service partnerships and all consumers for 2 fiscal years. We started with 08 and 9 and 9 and 10. And once again, we wanted to break this down by age group. We did this both for statewide as well as individual counties. And this specific project with UCLA has only focused on community systems and support, that one component. And the underlying goals here are just to sort of get into why we want to do this a little bit. We want to be able to understand, one, our ability to achieve this overarching goal of being able to monitor performance, the performance of our system with the available data. So we specifically instructed UCLA to use, to look at the full service partnerships. They use the data collection and reporting system, the DCR, and for all consumers they used the CSI, which is the Client and Service Information Data Collection System. So these two systems have, are available. Oh, they also used a few other things too, like the Consumer Perception Survey, and they looked at involuntary status information that's routinely collected. So if it was available, we said yes, see if this is something you can use to establish an indicator for these specific outcomes. And once they established some indicators, we wanted them to be able to create reporting templates so that counties had an idea of what we want them to be able to generate for us. And in essence, we're beginning to document trends via this process. This is sort of the beginning of this whole process. And so just looking at the bigger picture, why do we want to create outcomes and obtain performance indicators? The ultimate goal here is to assess the ability of the MHSA to achieve its goals. Again, the goals that are specifically defined within the MHSA at this point. And to do this, oftentimes you want to be able to designate a specific reporting period, say a fiscal year, look at what's been going on as far as those indicators, and then compare it to a benchmark. Now, we're certainly not at a point where we're comparing things at a benchmark, but that's sort of, in the long term, we'd like to be able to move into that direction. So when we look at the current information, the levels of the different indicators that we have, what can we actually say about them? How do we interpret them? We'd like to be able to do that because if you look at the information and sort of see, well, this specific item is not performing in the way we would expect it to, or it has in the past, for example, we know that maybe improvements need to be made or adjustments need to be made. So eventually, we want to be able to use this information to provide knowledge regarding current system performance so that we can have an idea of whether or not changes or improvements actually need to be made moving forward. And just to give you an idea of the types of outcomes and indicators we've focused on. I've just given you some examples here of the consumer level indicators and outcomes. So again, the indicators are how we are trying to measure them, and the outcomes are things that are just taken from the Act. So the Act says that one of its goals is to increase educational progress, for example. So UCLA tried to look at rates of suspension and expulsion as a way to determine whether or not we've achieved our goal of increasing educational process. The Act says we want to be able to increase employment. So as an indicator, we looked at rates of unemployment, we looked at rates of employment and paid and unpaid employment. Also, we want to be able to improve the housing situation. That's the outcome identified in the Act. And so we looked at a bunch of different indicators to see whether or not we're achieving that goal. So we looked at homelessness, days spent in family or foster homes, as well as independent residential status. And then finally, one of the consumer level indicators outlined in the Act is reducing justice system involvement. And so we looked at arrest rates as a potential indicator for that outcome. In this next page, I've got just some system level indicators. I won't read through them all, but again, just examples of things that we are hoping to achieve, the outcomes identified in the Act, and the indicators are how we could potentially be able to measure whether or not we are actually achieving those outcomes. And I've got here some examples of what UCLA found, and I just want to say this is all sort of preliminary. This is our first stab at trying to even establish what these indicators should be and then use the existing data. So we want to be able to further refine this. But in this slide, you can see homelessness for all consumers, and it's broken down for the 2 fiscal years, 8 and 9, and 9 and 10. And it's also further broken down by age group. So you've got your children, TAY, adults, and older adults. And you can sort of see the rates of homelessness. Here we're highest for adults. And on the next slide, I've got the same thing for FSPs. So in all instances, you can see for the most part, the rates of homelessness were not much, but were higher. Were higher across the different age groups and across both fiscal years. And what you can also notice in this at the bottom, we just have a huge percent of missing data, and so or unknown data, and that's sort of one of the limitations that UCLA has identified. So it's something that we need to address moving forward. Maybe this is not the best indicator. Maybe there are other ways to be able to capture the specific outcome that's identified in the Act. So we've got a lot of work to do here. And we are planning to do some more work here. So this is just next steps with regards to these projects. So with regards to the UCLA project, we do have a series of reports that will continue to be due in 2013 and 2014, where they will in essence add fiscal years onto what they've done. So at this point, next year, we've actually asked them to go back in time so that we can get a bit of a baseline and look at, they won't be able to do this for FSPs, but for all consumers, we want them to look at the indicators for years 2004 and 5, because that's actually prior to implementation of the Act. The Act was passed in 2004, began to be implemented in 2005, so that might enable us to sort of see whether or not we see changes in these indicators from basically after the Act was passed. And they'll also look at 2005 and 6. And I think in September, the next report would be they'll start to go forward again, because again they did fiscal years 8 and 9 and 9 and 10, and now they'll move forward to also do 10 and 11. And we'd in essence continue this process on an ongoing basis. But these next, or the last 3 bullets on this slide sort of say this is the bigger picture of what we need to do and have a vision for doing as we move forward to monitor these performance indicators. We definitely need to further refine the current indicators, perhaps add to some indicators. We may have to delete some of the current indicators. As I mentioned before, the ones that we focused on thus far are really only for the community services and support component, so we should be able to start to consider whether or not any of those could be used for prevention and early intervention. Do we need to establish others for PEI? What should be established for innovation so that we can monitor performance of these different components? There's a need to establish a benchmark. Again, this is thinking about long-term, how are we able to use the information that we collect year after year and be able to generate a bit of an interpretation of it. One idea is, again, to use that baseline information about what was going on prior to implementation of the Act, but there may be other things that we can be comparing to, so we would be able to, or we would like to be able to work collaboratively to consider what, for each of these indicators, what would we like to see? What do we think is possible to see so that we can establish a benchmark and then use that to basically enable us to know whether or not we're achieving what we want to be able to achieve each year. And generally, we just need to be able to establish a process for using this information. So once we know, yes, we have been meeting our goals, or no, we have not, what do we do about that? So we need to figure out how to sort of create an action plan based on that. Again, this is all sort of very big picture moving forward, many years into the future. We're sort of just at the beginning of this whole process. Okay, so going on to one of our other currently underway projects. Once again, we did this with UCLA, but their subcontractors, CLS Research, sort of took the lead on this. We asked them to look at, do an impact of services on client, evaluate the impact of services on client outcomes using a participatory research approach. So using that approach, for those of you who are not familiar, the idea of doing evaluation via participatory research is you, in essence, gather a group of, it could be stakeholders, oftentimes it's clients, those who are really invested in those services. So clients, their family members, other individuals who are really knowledgeable about the system, and they work with the evaluators throughout the entire process to contribute to the system and contribute to that whole process. So they used, they called their participatory research partners PEPs, participatory evaluation partners. So the PEPs helped the researchers at UCLA and CLS Research to choose 3 specific services that they felt as though should have been the focus of this study. So they chose peer support services, employment support services, and crisis intervention services. And we at the OAC wanted them to look at the impact of those services on individual outcomes. And working with the PEPs, the researchers identified employment, housing, and well-being as being the specific outcomes that everyone thought should be the focus. And in order to address that issue, they facilitated a statewide survey and also did 40 in-depth interviews. So they used both quantitative as well as qualitative methods to do this analysis. And here are some sample research questions. So just giving you an idea of what they were trying to do in the long run. Again, these questions were generated with the PEPs. So, for example, to what extent did the services exemplify a recovery or resilience orientation? What were the consumers' perceptions regarding access to those services? And the last three are sort of the main, like what are the impact of those services on the outcome? So did we see changes in employment after receiving those services? Did we see changes in housing, or did we see changes in recovery, resilience, and well-being after people received services? And our contractors have provided us with drafts of this report, and the final is actually due at the end of this year. We're really excited to see that come in, and it will be distributed to the public or made available to the public after it is shared with the commissioners, I think most likely maybe in January. So look out early next year to see the full report that's come out of this work. Okay, so this is just another project we currently have underway. This is called our Reducing Disparities in Access to Care project, and it's a contract we have going on with UC Davis. It has 2 primary objectives. The first one is to basically obtain trends in access to care via the California public mental health system based on both new admissions as well as all consumers. And we've asked our contractors to do this, breaking things down by, at a minimum, age, race and ethnicity, and gender. My hunch at this point is that that's probably all they can do based on the available data, because once again we've asked them to use only the available data to do this. And they are in the process now of providing us with an analytic plan as far as how they intend to address this specific objective. That's due at the end of this year. And then our second objective, objective 1 is again sort of the quantitative piece, and objective 2 is more of a qualitative piece. So using participatory research methods, once again, we've asked UC Davis to assess consumer and family member perspectives regarding the Act's impact on reducing disparities. And I don't know much about what they're planning yet, because once again they have their analytic plan is due to us by the end of the year. And so we're very much looking forward to hearing about how they plan to address both of these objectives. And in essence, we'll then begin to carry out the project and all the research next year. And they have reports related to each of these primary objectives due. One is due late in 2013, and then the final reports are due in early 2014. All right, so another project we have currently underway. This one is again with UCLA. CLS Research is again taking the lead. It's based on prevention and early intervention. Also has 2 primary objectives. Also is sort of parsed out in between, or into a quantitative and a qualitative piece a bit. So objective 1 here is assessment of both prevention and early intervention programs. And we've asked, actually I take it back, EMT is focusing on objective number 1, and CLS Research is focusing on objective number 2, all under the primary contractor, UCLA. So EMT has been working to look at program costs, the numbers of clients served as well as the spectrum of clients served, and different program components, and the focus of the programs that are going on currently for both prevention and early intervention. And that whole project will end in a report that's due September of next year. For our second objective, this is the one that CLS Research is focusing on. We've asked them to evaluate the impact of a cluster, what we're calling a cluster of early intervention programs. And at this point, we want them to identify series of programs that appear to use similar methods or have a similar scope or focus, so that we can have an understanding of, generally not at the program level, but when you have a series or clusters of programs who are doing generally the same thing, do we see an impact? Do we see positive outcomes stemming from those early intervention programs? And at this point, it appears as though they will most likely focus on, as far as the clusters, they'll look at programs that are focused on first break psychosis. The second cluster will most likely be on older adults who are showing the early signs and symptoms of depression. And the third cluster will most likely focus on children who have experienced trauma, who are also beginning to show early signs and symptoms of various mental health disorders. So we will, in essence, we've asked them to focus on those 3 clusters, go out into the state, go out into the counties, identify different programs that appear to have a focus in one of those 3 clusters, and either work with them to implement an evaluation or work with them to use the current evaluation efforts that the counties and the programs have underway, so that we can get the larger picture of whether or not generally programs in these clusters have an impact on outcomes that are, again, incorporated into the Act. So the outcomes here are things that are associated with untreated mental illness, so things like suicide, incarceration, unemployment, and prolonged suffering. And the report for Objective 2, that's going to take a little bit longer, so that's not due until early 2014. All right, so coming to the end of the projects we have currently underway, and you'll hear more about this from Dr. Joan Mizell later on this afternoon, but the OAC is in the process of developing an evaluation master plan. What we've asked Dr. Mizell, a contractor to the OAC, to do is develop an evaluation master plan for the California community-based mental health system with input from major stakeholders. And at this point, the plan is scheduled to be submitted by the end of the year so that we can hopefully have the OAC review and approve it early next year and then make it available to the public. And I won't go into any further details because Joan will be talking about this in much more detail later on this afternoon via another webinar. So I'm going to move along now to some of the upcoming evaluation projects that we have that will be underway soon. So the first is an evaluation of the community planning process. So our objective here is for a contractor, this hasn't been awarded yet, but a contractor will use the participatory research process once again to evaluate the MHSA community planning process. And we would like them to evaluate the impact and efficacy of the process for quality improvement purposes. And at this point, we're currently seeking RFPs. I believe they are due to the OAC by next Friday. I want to say it's December 14th. And we plan to, if all things go as planned, award the contract in January. So we will see what happens with that. Next, we will also hopefully soon begin an assessment of county innovation evaluations. So as most of you may know, counties can receive MHSA funds for what we call innovative programs. And the point of innovative programs are to sort of design and pilot and evaluate the efficacy of new approaches that they haven't necessarily used yet, but approaches that are consistent with MHSA values and intended outcomes. And in order for counties to be able to consider whether or not they want to be able to adopt those programs, they have to do an evaluation of the whole process. And so through this contract, we want to be able to first assess the quality of current innovation project evaluations. So we're not assessing or not wanting to assess the quality of the innovation projects themselves, but the quality of the evaluations that the counties are actually doing so that they can actually assess the quality of the innovation projects. And the second objective with this project will be to take steps to support county efforts to evaluate their innovation projects. So we see the value and the extremely high importance of being able to do high-quality evaluation of those innovation projects so we can tell whether or not they're projects that might be disseminated more widely or just even used within that specific county. And so through this process, we want to be able to provide support to the counties. And we will likely be releasing an RFP so that we can get bids to do this in early 2013. All right, and I think the last thing I'm going to share is we are also planning to continue to focus a bit on strengthening the community services and support data collection and reporting systems. So I spoke earlier about the project that we've got underway with Sacramento State, where they're focusing specifically on the DCR data collection system, which pertains specifically to the full service partnerships. We'd like for them or somebody to be able to broaden this to the CSI, which is the data collection used for all community services and support data collection. So the objective here is to first assess the quality of the CSS data that's available via the Client Services Information System and make recommendations for how to overcome those problems and limitations. And then the second objective is to identify and implement solutions for those problems with the Client Services Information System. And we hope that this project will also begin in 2013. All right, so I'm done with my whole spiel. So at this point, if folks have comments or questions, I'm happy to take those. I think Alice is going to help with that.
Okay, so everyone, we're in the Q&A period. If you raise your hand, I can unmute you, and then you can provide, say your question. And I'm going to do that individually. So does anyone want to raise their hand to ask a question? So Dr. Bradley. I'm not seeing anyone raising their hands.
All right. That
Hey,
works
look,
for me.
we've got Dr. Clark. Hold on.
Oh, okay.
Dr. Clark?
Yeah, thank you, Renee. It was excellent, very broad presentation and comprehensive. A couple of questions I had were with all of the efforts, I get a little confused about whether this is looking at the community mental health system or the Mental Health Service Act. I mean, you're drilling down to innovation or how they're evaluating innovations, but I'm wondering as far as the broader mental health system, and is that the charge of the Commission?
To my understanding at this point, according to the welfare and institution codes, I think I noted them in my second slide.
Right.
What these say are there's a statutory role for the OAC to evaluate California's community-based mental health system. To date, to my understanding, we have primarily focused on the Mental Health Services Act, and that's sort of where we are at. And I believe as we move forward, we may continue to consider how this could be broadened based on the direction that the Commission wants to move in.
Great. The other question is the missing data and the ability to render I don't want to call them conclusions, but results.
I mean, that's a significant issue. It's a very significant issue with anything that's been done using the currently available data. We have tried to put lots of effort towards at least getting a better understanding of the state of the current data collection systems. Clearly, we see lots of problems, and definitely we see ways to address the current problems within the current data collection systems. Ideally, I think we need to be addressing the current data collection and reporting system so that we can use the existing data, knowing that it has significant limitations. But we also need to be considering, on a larger scale, how we may be able to sort of move towards perhaps a new system where the old data collection systems can be rolled up into, and we can still access that, but at the same time trying to really overcome some of these larger issues with the current systems.
My last question is about dissemination. Up until your arrival, most of the folks in California were saying we didn't have a comprehensive set of evaluations and data on the impact of the Mental Health Service Act. You've done a very nice summary of saying what has been done, and I'm just concerned that some of those things that were ongoing or still are ongoing need to be disseminated so people know about them.
Oh, I agree totally. I mean, that's a big part of this is to, get all this information out to everybody, not only, the state and the counties, but, everybody throughout the state of California and the governor and the legislature. I know that we've talked about, as we get different deliverables in from our contractors, creating things like fact sheets and different, methods of dissemination. And I'm certainly open to, trying to do that moving forward. And I would like to see that happen more and more so, because I agree with you. I mean, I think hopefully having me here will help that, because we've got a bit of somebody to at least lead the efforts. But I think I agree. We need to be able to get all of this information out, because I don't think that everybody understands what has been done and even what we are doing now and intend to do in the future. So hopefully presentations like this will help.
Great.
Thank you.
Thank you.
So are there any other questions from the people on the webinar? Looks like there are none. Dr. Rowley, there's no more questions.
All right, well, thank you, everybody. I appreciate your listening, so thanks, and please let me know if you have any questions or anything. I'm happy to take questions at another time, so thank you.